Hi, this is Dr. Bhargava, and in this series, I have several interesting cases to share with you. We will start with this patient who came in with a history of trauma, and the trainee thought that in the penis involving the corpus corpora cavernosa, there is contrast extravasation. So here's the finding on the axial image at the level of the pelvis, and the finding is also seen here. This is where the corpora cavernosa are, two, and then the corpus spongiosum is right there. So there are no other signs of trauma. There is no fat stranding in this region. This is very rarely traumatized organ. There can be injury to the urethra, and in those cases, patients present with blood at the meatus. But for this to be abnormal is very unlikely. What we know this to be is normal variable enhancement of the corpora cavernosa that can be seen once in a while. In CTs of the abdomen and pelvis, it can look like this, but this is definitely not contrast extravasation from trauma. Here is another interesting finding: a female patient, and she has these very dense symmetric implants in her buttocks, also seen here on the coronal image. This is augmentation using silicone implants, and at the level of the chest there were some breast implants also. This is our next patient, a female who presented with this complex large cystic mass in the pelvis, seen here on the axial, coronal, and the sagittal images. So a finding like this is most likely a malignant ovarian tumor, a surface epithelial tumor, which could be either a serous or a mucinous adenocarcinoma. And I say it's malignant because you see wall thickening and enhancement. There are thick septations, also we see here enhancement. So those are suspicious features that we look for. But this was resected, and it turned out to be a very rare ovarian neuroendocrine tumor. And so this patient had a follow-up study where she presented with recurrence, and the follow-up was performed using DOTA-TATE PET-CT. And here is the rotating image. There is physiologic uptake in the pituitary, some uptake in the salivary glands, spleen more active than the liver, excretion from kidneys into the bladder. And this focus right here is seen right there. So that's metastatic lymph node in the left side of the pelvis, and also a right hilar lymph node. So a very rare metastatic ovarian neuroendocrine tumor. This is our next patient. We have two planar images from a technetium-99m SESTAMIB scan, and we are trying to do parathyroid imaging. And so as a part of the protocol, we inject the tracer and we acquire early images of the neck and the chest, and these are 10 to 15 minute delayed images. And then we acquire delayed images of the neck and the chest. These are about 2.5 to 3 hours delayed. And so on early images, we want to see uptake in the thyroid, and if there's a parathyroid adenoma, that will also show up here. And then on the delayed images, the uptake in the thyroid washes out like we see here. And if there was a parathyroid adenoma, it would show persistent uptake on the delayed images. That's how we diagnose parathyroid adenomas on SESTAMIB imaging. This was just an interesting case to show you normal distribution. Remember, SESTAMIB can be taken up in the lacrimals, salivary glands. We can see large vessels. This patient was probably injected in the right upper extremity. There is uptake and excretion from the liver, and there is myocardial uptake. So technetium-99m SESTAMIB is a myocardial perfusion tracer also, and under the market name of MiraLuma, it is also used for breast-specific gamma imaging to look for small breast cancers. Here is a chest x-ray, and we can see here that the lung fields are pretty much clear. The inspiratory effort is not very good. The cardiomediastinal silhouette is normal. The trachea is in midline, and the bones along with the soft tissues are normal. Here's a follow-up CT showing that the same patient at the same time had these infiltrates in bilateral lower lobes, probably from aspiration. But let's go back. Chest x-ray can be notoriously negative for small or subtle findings like these in this patient, bilateral lower lobe pneumonias. This is a very interesting imaging finding where a older patient came in with abdominal pain, and we performed a CT of the abdomen and pelvis. And this patient has this aortic aneurysm, which is seen right there. You see the wall calcification, you see the mural thrombus, and then we see this large left-sided retroperitoneal hematoma. And on these axial images, we see contrast extravasation into this retroperitoneal hematoma, which is pushing the left kidney in an anterior and lateral direction. So this abdominal aortic aneurysm is rupturing. We see the contrast extending from the aorta into this retroperitoneal hematoma. And the coronal image is again showing the aortic aneurysm with the mural thrombus. So this is what aortic aneurysm rupture looks like. A lot of times it's not a suddenly catastrophic event where there is sudden cardiac death because of the rupture and esanguination, but it can be a process where blood is slowly leaking into the retroperitoneal compartment and patients present with abdominal pain. And so if you see something like this, pick up the phone and call the vascular surgeon. They need to be taken to the OR for this to be repaired. This is another interesting finding, ultrasound of the scrotum in a patient on the right side. In the long axis view, we find that the testicle is okay. There is normal grayscale morphology, no focal lesions, and there on the color Doppler images, there is a blood flow to the testis. On the other side, we don't see much. We see these two hyperechoic lines, one besides the other, and then there is an acoustic shadow posterior to that. And so this is the classic appearance of a testicular prosthesis. So once in a while we come across this finding where for some reason, sometimes trauma, sometimes severe infection, or even tumor, one of the testes has been removed and the patient has opted to put in a prosthesis where they want their scrotum to look symmetric. And so this is a prosthesis which is shaped like a testis, and it is placed inside the scrotum, and the wall of it would be echogenic like seen here, and posteriorly there will be acoustic shadowing, and that's what a testicular prosthesis would look like on ultrasound. All right, so here we have PSMA PET CTs in a patient with metastatic prostate cancer. So this is their initial staging. Rotating image where we see focal intense uptake in the prostate, we see metastatic lymphadenopathy, and then they underwent systemic treatment, and we find that they've responded to therapy. The prostate cancer in the prostate is smaller, and the metastatic retroperitoneal lymphadenopathy has completely resolved. So PSMA PET CT is a good modality to look for response to therapy in patients who have prostate cancer. These are some representative images, cross-sectional images showing the primary prostate cancer, retroperitoneal lymphadenopathy, and the primary tumor getting smaller, and the retroperitoneal lymphadenopathy is much better on the follow-up PET CT. This is our next patient, and I'm showing you a single sagittal T2 weighted image. She is postmenopausal. We find that the uterus is atrophic, and we look at the endometrium. There are no focal lesions, but the endometrium shows this proliferation into the myometrium, right? And this finding is adenomyosis, which can be seen in postmenopausal women also. This is our next patient. They initially had a ultrasound of the kidneys, where in the long axis view and in the transaxial image we see this hyperechoic focus in the kidney. We know that fat is hyperechoic, right? And so here is a corresponding CT showing this fat attenuation lesion in the right kidney, and these are angiomyolipomas. This is our next patient. They presented with a testicular ultrasound. We find that the left testicle is normal in terms of its grayscale morphology and color Doppler appearance. On the right side, we find that there is heterogeneity. There is appearance of several scattered masses, and this testicle is very hyperemic. And so in a 75-year-old male, this is not going to be a seminoma or a non-seminomatous germ cell tumor. This turned out to be lymphoma. Here's our next patient, and we're looking at perfusion and ventilation images from the VQ scan. And so I tell trainees to find the anterior ventilation image and compare it to anterior perfusion image, and then similarly find the posterior ventilation image and compare it to the posterior perfusion image. And comparing these two set of images, we find that there are no perfusion defects that are mismatched. So this is either a low probability VQ scan or a normal VQ scan. So to make that determination, we look at the posterior oblique views of perfusion here on the left side, and this is on the right side. And when patients have normal perfusion, there is a gradient of activity from below upwards and from the posterior to the anterior aspect. So there will be more activity in this region, and as we go superiorly and anteriorly, there will be less activity. So sometimes, like here, the pattern is reversed. It's called redistribution of perfusion to anterior and superior lung segments. And that finding is associated with CHF, or congestive cardiac failure. This is their chest X-ray showing a very enlarged cardiac silhouette and perihilar vascular congestion consistent with congestive cardiac failure. This is our next patient, and this patient had a prior FDG PET-CT. Their diagnosis is myeloma, and the prior study was after treatment and it was reported as negative. Then they came back with lab findings suspicious for recurrent myeloma. We repeated an FDG PET, and here we see this subtle finding of increased uptake diffusely in the marrow. Right, I am hopeful that you're able to appreciate that finding. Right now, compare the uptake in the bones to the prior study. We called it positive. Also, looking at the prior skull in the bone windows and looking at the current study, we find that there are new lytic lesions, small lytic lesions in the skull compared to the prior. And so both things together, we said that this was a recurrent myeloma, and that's what it turned out to be. Here's our next patient, also with history of prostate cancer, and we performed a PSMA PET-CT. This is the rotating image showing multifocal tumor in the prostate, and this focus in the rib. So the tumor is seen here, and the rib focus is seen here. Not much can be said about this small focus in the bone windows. It just looks abnormal, doesn't look like a healing fracture or a tumor. So this patient underwent systemic treatment, and this is the post-treatment study, where on the rotating image we find that the lesions in the prostate have resolved, but this focus remains, and because this focus remains, we can assume that this is a benign and not metastatic. Here's our next patient. History here was prior renal cell carcinoma and left-sided nephrectomy. On a CT of the abdomen and pelvis, we find that there are nephrectomy clips on the left side. The right kidney looks normal. And then we saw these abnormal enhancing soft tissue density in the omentum here and near the midline, and also a focus in the left lower quadrant. This patient also had a FDG PET-CT. And here's the rotating image, and those tumors, those enhancing foci in the abdomen and pelvis are showing FDG uptake consistent with renal cell carcinoma recurrence, and those findings are seen right here and also seen here and here. So renal cell carcinoma is FDG avid, and FDG PET-CT is a good study to follow up patients who are suspected of having metastatic disease or recurrence after surgery. The reason we don't use FDG PET-CT for initial staging is because FDG physiologically is excreted from the kidneys into the urinary bladder, and because of that, a RCC in the kidney can be missed on FDG PET-CT scan. Here's our next patient. A female with a breast prosthesis, some inflammatory uptake in the right breast. And the interesting finding here is look at the aorta and the large vessels. There is mural thickening and FDG uptake, also seen here, suggestive of large vessel vasculitis. Another patient with PSMA PET-CT, we see uptake in the prostate. And then we see this linear uptake extending from the urinary bladder. They also have a renal transplant in the right hemipelvis. And so the tumor in the prostate is seen here on the fused images. And this focus right here is the ureter that is going from the transplanted kidney and anastomosing to the superior aspect of the right side of the bladder. And at the site of anastomosis, there is some stasis where we see urine activity. This isn't metastatic disease. This is our next patient, another patient with history of prostate cancer, and we performed a PSMA PET-CT. Their prostate is enlarged as seen on the CT. There is probably some chronic outlet obstruction because of which there is urinary bladder mural thickening. We see focal uptake right there, which is in the right seminal vesicle. So the tumor, which is more inferiorly seen right here, has extended superiorly to involve the seminal vesicle on the right side. This patient was previously treated with radiation, and so here their diagnosis is prostate cancer recurrence. Here's our next patient, also with history of prostate cancer, and we're looking at a PSMA PET-CT. The rotating image shows this appearance of the bladder with this part extending inferiorly, and that part that is extending inferiorly is seen right there as a hypodensity. And there is some urine activity, and that's a normal appearance after prostatectomy when we have performed a vesico-urethral anastomosis. Next patient also has history of prostate cancer. We are looking at PSMA PET-CT. We see the primary tumor in the prostate. There is no evidence of metastatic disease. That tumor is seen right here on the fused PET-CT images in the right peripheral zone of the prostate, and we have some corresponding findings on the MRI. There is a low T2 signal focus right there, which shows restricted diffusion because there is high signal on DWI and low signal on ADC images. So there's a good concordance in this case between the PSMA PET-CT and the prostate MRI. Thank you for watching.